This is my lab makeup for the chest tube assessment. First, I'll begin by stating what the indications of a chest tube are, which are to evacuate air or fluid from the chest cavity or mediasternum, helps reestablish lung expansion and restore breathing dynamics by removing that air and fluid, or by facilitating post-operative collection and reestablishment of the blood from the patient's pleural cavity. Okay, so once I get a hold of my patient, I'm going to do a thorough assessment. First, starting off with the vital signs, like the usual BPs, heart rates, temperature, but paying close attention to the respiratory rate, which should be between the normal ranges of 12 and 20 respirators per minute. Otherwise, my patient might have difficulty breathing, so if that is the case, I'm going to check for other symptoms of labored breathing, such as nasal flaring, triprodding, shortness of breath, cyanosis, pursed lips, or simply by asking if they can breathe properly. After asking if the patient is able to breathe properly, I'm still going to make sure that there aren't any other things going on within the chest cavity. By doing so, I'm going to watch their breathing and do a full auscultation in the front and the back with a stethoscope. So just checking each lobes one at a time, maybe even doing so for a full minute, especially within the affected area. If I don't notice any crackling or wheezing or any absent sounds, then everything's good to go and I can continue. Afterwards, if there aren't any other concerns, I'm going to move on and do a chest tube assessment, starting with the dressing up on the side. It's like so on my mannequin, just making sure that's intact, there's no drainage or any pain, and if there's any pain, I'm going to be willing to ask the patient if they want any PRNs or other means of comfort. Afterwards, I'm going to check the tubing and make sure all the connections are intact, if there's any holes, or if anything's loose or anything's draining from any point of connections. Otherwise, I'm going to keep going up into my chest drain, making sure there's no bubbling up in this chamber. If there's trouble bubbling, such as there's a leak in the system, the bubbles will continue up until 5, and at that point I'm going to go ask for help, maybe a physician or any other nurses, just to stop the connection and make sure that the patient is okay. And if everything is okay from there, I'm going to look at these chambers, just make sure that I make note of the fluid assessment, just the colors, the volumes, and if there's any other precipitation or any sorts. And from there, I'm going to take a look at chamber A, which this just means that the suction at the back of the room is correlated with the suction on the system.
Hello?
Hi, Melissa. I'm Marianne. I'm just going to be your student nurse for the day. So your doctor had ordered me to do a dressing change for your chest tube. Would that be okay with you in a little bit?
Mm-hmm.
Sounds good. Before I start, I'm just going to do a quick assessment, just make sure everything's running properly.
Okay.
How's your breathing going?
It's better than yesterday, but I'm in quite a bit of pain.
Oh, I'm sorry to hear. I can go get you a PRN as soon as possible, especially before the change, just so you're not in uncomfortable.
Thank you.
And then, yeah, so I'm going to go ahead and start with your rest. So first, I'm just going to listen to your lungs. Just relax and just take a couple of deep breaths for me. Everything sounds pretty clear. Good. And a couple more breaths. Okay, I'm just going to reach around to the side here. Don't mind me. Good. Alright, so everything seems pretty normal as usual. And I'm just going to check a look at your connection. Did you notice any hissing sounds or anything? Anything weird? Alright, no holes. Okay. I'm glad you keep the drain below your chest. Okay, and there's no bubbling. That means there's no leakage. You should let me know if there are any bubbles. Oh, and you're up at 100 mils today, which is a lot better than the past couple days. Okay, so I'll go get you your Tylenol and I'll be right back. So next up, I'm just going to demonstrate how to do a dressing change for the chest tube. And I have my friend Melissa here to help me out.
Hello?
Hi there, Melissa. How's the Tylenol working out for you?
Really well, thank
Good.
you.
I'm very glad. And would it be okay if we start with the dressing change?
Yes.
Sounds good to me. Okay. Alright, I'm just gonna be back. Just gonna quickly wash my hands. Okay. And have you ever had a dressing change done before?
Yes.
Good. So you should just let me know if you do feel any pain during the process, okay?
Okay.
Okay, so I'm just going to put just regular drainage sponge on top of the site. And then over that sponge, I'm going to put some Mefix, which is bandage. Put this to the side for now. I'm just going to move your dressing now, okay? Drainage, that's okay. I'm just gonna go get some new gloves. I'll be back. Okay. Start. There you go. Here, how are you doing?
Well, thank you.
No pain at all, I hope. And how much drainage usually comes out of the site, if any?
Not.
Not much. Okay, so I think one sponge will do. But if it does have to be more for any reason, just let me know. We can do another change.
Okay.
Okay. down to rest, and then let you know when your afternoon meds are ready.
Thank you.
And after the dressing change has been completed, I'm just going to keep checking on the patient, just making sure that there aren't any adverse events happening or any more drainage or anything loose with the connections. And once everything is completed and everything seems okay, I'm going to go ahead and document.